then action potential, traveling of action potential in the vestibulocochlear nerve, right? And finally the cochlear nerve, right? And that goes to auditory cortex. This total pathway is checked by an electrophysiological investigation, which is called brainstem evoked response audiometry, or BERA, or it is also called BAER, or brainstem auditory evoked response, or called AEP, that is auditory evoked potential. Next slide. Okay. So already discussed. Next slide. Okay, now the pathway of auditory system. So how to remember the pathway of auditory system? Just remember one mnemonic, that is echo-lima. Okay. So we start with 8th cranial nerve, then cochlear nerve, then olives, specifically superior olive, then lateral lemniscus, inferior colliculi, medial geniculate body, and auditory cortex. Okay. So very commonly we ask in the Viva examination, tell me the auditory pathway, tell me the visual pathway, tell me the light reflex pathway. Okay, you must remember for your examination purpose the pathways of light reflex, pathways of vision, and pathways of auditory input, right? Okay. So I repeat, echo-lima, remember the mnemonic echo-lima, 8th cranial nerve, cochlear nerve, olive, lateral lemniscus, inferior colliculi, medial geniculate body. Remember medial geniculate body in case of auditory, and it is lateral geniculate body in case of vision, right? In case of vision. Okay. So medial geniculate body, remember, do not confuse medial geniculate body and lateral geniculate body. Medial geniculate body is for auditory and lateral geniculate body is for vision. Okay. Okay. Next slide. Okay, so you don't need every details about auditory evoked potential, because you are not going to perform this experiment. It is a practical topic. You are not going to do auditory evoked response in a patient right now. Okay, but you need to know the principle, how to do it, right? And on what principle we do it. Okay. Okay, so measures auditory evoked response potential, or auditory evoked response. So it measures the function of auditory nerve and its pathway to auditory cortex. First of all, ঠিক আছে, আমরা কি চেক করছি? অডিটরি নার্ভস থেকে কর্টেক্স পর্যন্ত যে পাথওয়েটা আছে সেই পাথওয়ের ইন্টিগ্রিটিটা চেক করছি, রাইট? Whether the pathway is intact or not, if there is any damage somewhere, right? Okay, second, it is an objective test. Okay, it is objective test. Okay, so I will produce a sound with the help of a headphone. Okay, and the patient is usually sedated or anesthetized. Patient is either anesthetized or patient is sedated, and with the help of a headphone we produce a sound towards the patient's ear. Okay, so sound is produced in the ear of the patient with the help of headphones, and a standard broadband monaural click is produced to stimulate the ear, to stimulate the auditory nerve, to stimulate the hair cells, right? Okay, and the potential is recorded at brainstem or upper pons, which is the site of impulse reception. Okay, upper pons. Okay, so potential is recorded at the brainstem or upper pons, which is the site of impulse generation. So this is the very basic principle of auditory evoked response audiometry. Next. So what are the waves that we get in BERA, or auditory evoked potential? So there are 5 waves. Wave 1 is due to action potential of the vestibulocochlear or 8th cranial nerve, right? Wave 2 is specifically cochlear nucleus. Wave 3 is ipsilateral superior olivary nucleus. You remember the auditory pathway, it goes through olive, echo-lima, ECO, over olive. Okay, so wave 3, it is due to ipsilateral superior olivary nucleus, right? Wave 4 is lateral lemniscus, echo-lima, LL. Okay, so wave 4 is for lateral lemniscus, and wave 5 is for inferior colliculus. Okay, so say for example in the auditory evoked response, in the curve we don't see the wave 4. Okay, we don't see the wave 4. That means there are some issue with the lateral lemniscus. We don't see the wave 4 and 5. That means there is a block, or there is some damage, there is some neuronal lesion, or there is some pathology at the lateral lemniscus. So what you will see in the response, you will see only wave 1, 2 and 3 and not 4 and 5, right? Getting my point? So in the impulse conduction from the cochlear nerve to the auditory cortex, we can detect with the help of auditory evoked potential the location of any pathology or damage in the auditory pathway, right? Okay. So if there is any damage in the superior olivary nucleus, you will get only wave 1 and wave 2 and not beyond 3, 4, 5 will be absent. Getting my point? Similarly, if there is any lesion in the lateral lemniscus, you will get 1, 2, 3, okay, and not 4 and 5. So this is how you can detect the location of any pathology or any lesion in the auditory pathway. Clear? That much is sufficient for you at your level to understand about auditory evoked potential or brainstem auditory evoked response. Okay, moving on. This much is quite sufficient for writing a short note, because you will not face, definitely you will not face a long question on brainstem auditory evoked response. It will hardly be a short note. Okay, next. Okay, now indication. Okay, indication. What are the purpose that we will do brainstem auditory evoked response? What is the purpose? So first of all, to rule out hearing pathologies in an infant or comatose patient or mentally challenged patient. Okay, so বাচ্চারা বা comatose patient তারা তো বলতে পারছে না আমি শুনতে পাচ্ছি না, ঠিক আছে? So to test whether the child is deaf or not, if there is any neurological lesion in the auditory pathway, neurological damage in the auditory pathway, any problem in the auditory pathway, you can detect by simply performing an auditory evoked response potential, right? Clear? So to rule out hearing pathologies in infant, comatose patient or mentally challenged patient, and also for the screening of multiple sclerosis and acoustic neuroma. Okay, what is acoustic neuroma? It is 8th cranial nerve tumor. Okay, 8th cranial nerve malignant lesion. Okay, acoustic neuroma. It is a neuronal tumor of 8th cranial nerve. Clear? Okay, and here is the basic diagram. Okay, so sound stimulus through earphone, right? And here is the receiver, and is the video display and printer. Okay, there is an amplifier. This is the basic arrangement of brainstem auditory evoked response. Slide. Okay, now visual. So quite similar, with the help of auditory evoked potential, we check the auditory pathway. Now the visual pathway. Okay, now the visual pathway to test the optic nerve, right? To test the optic nerve to the occipital cortex or the visual cortex. You know the visual pathway. It starts from retina and goes to occipital cortex. Okay, I guess all of you know what is the visual pathway. Okay, it starts from retina, optic nerve, then optic tract, optic chiasma, then optic nerve, yes, lateral geniculate body, then optic radiation, then occipital cortex. Okay, very simple. Okay, so visual evoked potential, right? Next slide. Okay, so again it is the potential recorded at occipital cortex. We place the electrodes over the occipital cortex. Detail not required for your level. What are the specific position of the leads, because you are not going to perform right now. You need to know the basic principle of performing visual evoked potential. So potential recorded at the occipital cortex when there is an image projected on the retina. Okay, retina में कुछ image project किया जाता है. So what are the image? Usually light. Flashlight are produced in front of the patient eye, and it is to understand the integrity of visual pathway. Okay, to understand the visual pathway is intact or not. Okay, visual pathway starting from optic nerve, optic chiasma, optic tract, lateral geniculate body. Okay, optic radiation, then occipital cortex. This whole pathway is intact or not, whether there is any pathology, whether any lesion, any tumor in the pathway or not. Right? So the subject is shown flashlight or a pattern, picture pattern, right? The subject is shown either a flashlight or some specific pattern. Okay, black and white stripe, okay, or any kind of pattern. you can show to the patient, right? And we classify depending on whether flashlight is shown to the patient or any kind of pattern is shown to the patient. It is called pattern VEP, or it may also be called flash VEP. If flash is shown, the test is called flash VEP. If pattern is shown, the test is called pattern VEP. Okay. So the subject is shown flash or light pattern, it is either called flash VEP or pattern VEP accordingly, right? And the normal visual evoked response is marked by a period of latency. Okay. So you are showing some picture to the patient, some pattern to the patient, or some flashlight in front of the patient eye, and your electrode is placed, that is which is capturing the signal, right? It is placed over the occipital cortex, back of the head, right? Occipital cortex. So there will be some time when you start the flashlight or you show the image to the patient, and that image is processed into electrical response or action potential from the ganglion cell, right, to the retina, right, to the retina. Then it goes to optic nerve, optic chiasma, optic tract, okay, and finally through lateral geniculate body, optic radiation finally goes to occipital cortex, okay. So there is some time lag. You show the light or pattern to the patient and catching the response, electrical response from the back of the head. So there is some delay, okay. So this delay is called the latency. So normal visual evoked response is marked by a period of latency, and that latency occurs for the light impulse to travel to occipital cortex. Okay, the light impulse, it needs some time to travel to occipital cortex, right? Okay, then there is a negative wave at 75 milliseconds, and there is a positive wave at 100 milliseconds. Okay, we call it N75, that means negative 75, and P100, it is the positive wave at 100 milliseconds. And remember, the P100 is the most significant. Okay, P100 is the most significant. If P100 is not present, that means there is some problem in the auditory pathway. P100 is the most important signal we receive from the occipital cortex. Next slide. Okay, see, so this much is the latency. This much is the latency. Here is the time scale. Here is the time scale at point 0. Here we show the flashlight. At this point, we show the flashlight or pattern to the patient, right? And this much is the delay. This much is the delay, around 70 milliseconds. Around 70 milliseconds is the latency. And after this latency, these are minor fluctuations. Okay. So after 70 milliseconds, we get a negative wave at 75 milliseconds. At 75 milliseconds, we get a negative wave. And this negative wave is called N75. And immediately after this N75, at 100 milliseconds, we get a positive wave. Okay. It is called P100, and remember, P100 is the most significant. Okay. P100 is the most significant for interpretation. Okay. There are a few implications of N75 and N135 as well, but most important is P100. It must be present. Okay. It must be present in the visual evoked potential. Okay. If P100 is not present, that means definitely there is some problem within the neuronal pathway. Okay, clear? Okay, this much is sufficient for you. Next slide. Okay, indication. When to do visual evoked potential, right? Indication means when to do visual evoked potential. Amra visual evoked potential test korbo kokhon. Okay, so testing visual acuity in infants. How to test visual acuity you have already done in your practical session. How to test visual acuity? What chart? Snellen's chart. Okay. So for Snellen's chart, you need to read something, ABCD or C. Okay. You need to read something. You need to see. But in case of infants who cannot tell, right? So testing visual acuity in infants. Okay. Testing visual acuity in infants to rule out malingering. Okay. Some patient is malingering. But it is not real. Maybe it is not real. So you check it. You check it by doing visual evoked potential, right? To diagnose optic nerve disorder, definitely follow up in demyelinating disorder. Okay, demyelinating disorder, like any kind of demyelinating disorder where myelination is lost, nerve myelination is lost. Any demyelinating disease, and for medico-legal cases, okay, where myelin sheath is lost, okay. We told many a times multiple sclerosis, Alzheimer's disease, right? B12 deficiency. So these are causes of demyelination. There are many causes, many demyelinating diseases where nerve myelination is lost. Okay, so follow up in demyelinating disorder. Follow up means if you perform serial visual evoked potential in a patient of demyelinating disorder, most of the demyelinating disorders are progressive in nature. Okay, most of the demyelinating disorders are progressive in nature. Okay, that we cannot stop. Dhire dhire बढ़ जाता है, right? So progressive disease. So if you perform serial, every year you are performing visual evoked potential, the height of P100, which is the most significant. Okay, the height of P100 or the amplitude of P100, it gradually decreases in case of progressive demyelinating disorder. So to follow up in a demyelinating disorder, কি patient আরো খারাপ হয়ে যাচ্ছে না আরো ঠিক থাকছে, ঠিক আছে, আমরা বারবার every year we can perform, or every 6 months or every year we can perform visual evoked potential to check the progress of the disease, right? Okay, and for medico legal purposes definitely. Next, okay, next topic is brain death. These are chota topics, short note topics: visual evoked potential, auditory evoked potential, brain death. Okay, these are small topic. You do not expect any long question from this, but you may get short notes. Okay, and these are included in your NMC curriculum or syllabus. Okay, brain death. Next slide. So first of all, what is brain death? Okay, first know the definition of brain death. So a condition where there is irreversible damage to brain. The damage is irreversible, it will not revert back. So the most important, you need to write this word, highlight this word, irreversible. Okay, so the condition where there is irreversible damage to brain characterized by loss of function. So brain function loss which is irreversible. Okay, brain cannot be revived back, right? So a condition where there is irreversible damage to brain characterized by loss of function, cerebral perfusion is absent. Okay, brain में blood circulation नहीं है. Okay, cerebral perfusion is absent. However, major organs like heart, lungs are functioning with the help of mechanical ventilation. Okay, so it is very common in ICU situation where the patient is ventilated. Okay, where the patient is ventilated due to the disease process, brain function is lost and it is permanent. Okay, brain function is lost, it is permanent, and it is called brain dead. But still the patient is viable, other organs are viable because artificially the patient is ventilated. Artificially the patient is ventilated and respiration is going on, right? Respiration is going on. Okay, so it is called brain death. And from a brain death patient, organs can be harvested. From a brain dead patient's organ can be harvested. So what are those organs? Heart, lung, liver, pancreas, right? These organs can be harvested and can be transplanted to another patient. Okay, next slide. Okay, what are the criteria? Okay, so to declare a patient as brain dead, to declare a patient in the ICU setting brain dead, you need to have some criteria. Okay, so usually there are a team of doctors who declare a patient brain dead. Okay, so when to declare brain dead, there are some criteria. Number one, it should be deep unresponsive coma. Okay, and if you perform electroencephalogram, it will be a flat line. Just like cardiac arrest, you check ECG and instead of getting PQRST waves, you get a flat wave, right? A flat line. Okay, similarly in electroencephalogram, you perform EEG on a brain dead patient, it will be a flat line. That means there is absolutely no electrical activity of the brain neurons. Okay. Then you check for light reflex, pupillary light reflex. So there is no reflex. Okay, absent pupillary light reflex. Then you check corneal reflex. So absent corneal reflex. Then there is apnea. Okay, apnea means inability to initiate respiration in presence of high partial pressure of carbon dioxide. Even if there is high partial pressure of carbon dioxide, respiration is not initiated. Respiration is not initiated even at the presence of high partial pressure, arterial partial pressure of carbon dioxide, right? Okay. Now, who are competent or eligible to declare brain dead? It is usually the doctors appointed by Government of India are eligible to provide brain death certificates, right? And 2 certificates are usually required at an interval of 6 hours. Okay, am I correct? It is, yes, it is 6 hours. Okay, so 2 certifications are required. So you check the patient now and after 6 hours. Okay, so one certificate will be issued now and next certificate will be issued after 6 hours. So if it is same, that means, you know, unresponsive coma, flat EEG, absent pupillary light reflex, absent corneal reflex, there is apnea, right? So if these are all criteria are met on 2 occasions, 6 hours apart, we can finally declare the patient as brain dead. And remember, the team of doctors who declare brain death, one of the doctor must be a neurologist, right? One doctor should be a neurologist. Clear? So this is all about brain death. Again, 3-4 marks or 5 marks short note is sufficient, right? Next. Okay, now this is again another short note for you, which is the question may come as limbic system, the question may come as limbic system, or the question may also come as Pepage circuit. Okay, Pepage circuit on the name of the scientist who discovered, okay, name of the anatomist who discovered Pepage circuit. Okay, so Pepage circuit or limbic system. Next slide. So it is a set of connection. Simply, Pepage circuit is a set of connection in the limbic system. Okay, it is a set of connection called Pepage circuit. What is its role? The major role is memory encode, okay, encoding memory, genesis of electroencephalogram, and finally most important is emotion. Okay, so it is this specific area or connection within the brain which controls your anger, which controls your emotion, which controls your excitement, right, and controls your sexual behavior, right. So emotion, anger, excitement and sexual behavior, all these are controlled by a specific area of brain, or you can call rather than specific area, a specific connection within the brain. It is called Pepage circuit. Okay, and you can expect a short note on Pepage circuit in your first professional MBBS examination, right. It is the last topic I am telling today. Okay, today's class will be short. I'll take only 40 to 45 minutes. Okay. So it plays important role in encoding memory, genesis of EEG. This is a secondary function, but the major function of Pepage circuit is related to your emotion. That means excitement, anger, sexual behavior, right. Next slide. Okay, so again the major functions of Pepage circuit. So autonomic regulation with the help of amygdala, regulation of feeding behavior, regulation of sexual behavior, emotional behavior and motivational regulation. So these 5 things are the major functions of Pepage circuit or your limbic system. Okay, next slide. Next slide. See this circuitry, and you need to this. Okay, you need to remember this. So we can start with hippocampus. Okay, we can start with hippocampus. So do you remember hippocampus was during my class on memory processing? I told many a times that Hippocampus is the gateway of memory. Okay, hippocampus is your gateway of memory, and it is the area where short-term memory is converted to long-term memory. Your long-term memory is stored in your neocortex or cerebral cortex. Okay, and your immediate memory, which is there in the reticular activating system. And we had compared reticular activating system or RAS with the RAM, random access memory of a computer, right? So RAS is equal to RAM. So I am telling you my phone number and I am asking you to repeat. So your reticular activating system is working. That means your random access memory is working. Computer's RAM is working, right? If I ask you your birthday, okay, if I ask you your birthday, you take it from your cerebral cortex because it is your long-term memory, it is your permanent memory. Okay, your birthday is a permanent memory which you retrieve from your cerebral